chat. Okay, hello. So today we're gonna do the secondary hemostasis and disorders. Let me just put this. Okay. We did primary hemostasis and disorders last week, so now this is obviously the second step. Okay, so remember with hemostasis, there are two steps. There's the primary hemostasis, which is what we did. That's very, very quick. And then there's the secondary hemostasis. This is delayed. So this is what we're covering today in red. This is entirely involved with the coagulation cascade. The overall goal of the coagulation cascade is basically you want to make the platelet plug super strong with what's known as fibrin cross-linking, and that is the end product, the end goal, that is what the goal of the coagulation cascade and secondary hemostasis is, to make a cross-linked fibrin clot. And I'm really emphasizing the cross-linked because there are certain, coagulation disorders where you get all the way down the coagulation cascade, but you don't get that cross-link. And that's a disorder because you don't get a strong clot. So this is the end goal. We want a cross-linked fibrin clot. Okay, turns orange. All right, so we'll talk briefly about coagulation proteins. So coagulation proteins, these are zymogens. So they're back, just like with the complement system with immunology, we have zymogens once again. So zymogens, if you need a little refresher, these are proteins that are proteins that are made by the liver, and I emphasize liver because I do think we talk about it. I have it on like a future slide. But if you have like a liver issue, cirrhosis, hepatitis, something like that, one of the side effects might be, like bleeding disorders. Like you can't make clots. And the reason why is because the liver can't make these clotting proteins, so you can't clot. So, and I think I had this on a slide, but one of the ways to, if you actually want to test liver function quickly, you do a PT and a PTT. Very quick way to test if your liver is working properly because you're not making clotting proteins. If the liver's really sick, it's not going to make those proteins. Okay. And then remember zymogens, they're already made, they're already there, but in order to become activated, they need to be cleaved. So each one of these clotting proteins needs to be cleaved, and then they activate the next one along the pathway. It's exactly like the complement cascade from immunology. The other thing to remember is that zymogens are consumed. So it's going to be kind of like I said, kind of like the complement system, where if they're being consumed, if the pathway is moving along, if you have less of a zymogen, then that means the cascade is progressing forward, it's working. All right, so you want less of that zymogen. That means it's working, it's going through. Okay, because remember, they're already there. And then if once they get cleaved and they go away, you know that it's working. It's not like, oh, we're waiting for them to be made, so if there's less of them, it's not working. It's the opposite. They're there, so if there's less, they're cleaved, they moved on to the next one. Okay, so just if you ever are like just doubting anything with these coagulation proteins, the coagulation cascade, think back to the complement cascade. It's exactly the same. Here's my little you need to knows. Just this is for boards, for your exam, for everything. These are just things that will come up. The factor names, the common name. So what that means, and I'll show you, I have a chart for you guys. Even the Roman numerals, I tried to put the Roman numerals on here as much as possible instead of writing factor 12. I wrote XII because you need to know, don't get confused. Don't know that the answer is factor 12 and then pick factor 7. Because you're the VII is 7 instead of the XII. So know your Roman numerals. It sounds really silly, but people get them wrong, and then they're like, oh my God, because it's just so silly. You knew the answer. So know the Roman numerals, know those names, the factor names, the common name for that factor. They're all interchangeable in the exam. Where each factor is made, like I said, mostly they're made in the liver, but there are I think there's 3 exceptions where they're not made in the liver. And then which factors are in which pathway. And we're going to go through that. But the extrinsic pathway, the intrinsic pathway, or the common pathway. Or both, or all. Okay, so then notes on complement. This is straight up from the immuno lectures. As a reminder, zymogen pathways are tricky. Less of the zymogen, the pathway is progressing. And I'm just emphasizing this because this is how the PT and PTT play into understanding how zymogens work. So again, if you have less of the zymogen, you're moving through the pathway, so you're using up that zymogen. So think of it in terms of C4. So if we have tons and tons of these microbial surfaces or antigen antibody complexes, you're going to get a lot of, the complement cascade getting activated. So here's like the MBL with its MASPs. So it's kind of like this is the alternative path, or sorry, the mannose binding lectin pathway. It's going to bind to the microbial surfaces. C4 is going to get cleaved into C4a and C4b. Now C4 is being consumed, so there's low levels of it. And if you test for C4, there's less C4 levels. This is normal. This is good. We want less C4 because that means it's going through. The pathology would be if you had high levels of C4 or like normal levels of C4 when you shouldn't. That means it's not progressing through. And we'll tie this into a PT and a PTT when we talk about the coagulation cascade. Okay, so here's this. So first we're going to talk about the intrinsic pathway. The intrinsic pathway is the one that's a little bit more involved. The extrinsic is not as involved. And kind of how I made this chart. Oh, no. Oh my gosh, sorry, I'm pressing buttons. Okay, so with this chart over here, like right here, blue, like if it's blue, that means it's always there. That's why I have my zymogens already there. They're already present. So we have 12, 11, 9, and 8. They're made by the liver, right? So they're there. The liver just makes them all the time. But again, this is why zymogen pathways exist in the body, is they're not activated right away. And it's kind of just like a quality control type thing. Like they're there, but we didn't activate them yet. So it's kind of like a checkpoint. But so blue is always there. And then orange, when you see these orange arrows that are going to come up, that means that is created once the pathway gets activated. Okay. So looking kind of over here, this is like a good chart to know for your exam and for boards. But the factor, so what's the factor name? So here's factor 12. Like I said, know these Roman numerals. So here's factor 12. The full name of it is Hagman factor, and it's made in the liver. Right here, this is factor 11. So XI is 11. The full name for this is plasma thromboplastin antecedent. Annoying. And it's created in the liver. Factor 9, this is Christmas factor. It's because it was like discovered on Christmas, which I just think is funny. And then it's also made in the liver. And I put vitamin K here because this will come up with warfarin later. This is a vitamin K dependent factor. And if you have done like the sketchy for warfarin yet or have reviewed warfarin, which is Coumadin, you know that it's going to inhibit the vitamin K dependent factors. So I just put them here whenever I can. But here it is dependent on vitamin K. And then factor 8, this is anti-hemophilic factor, and then it's made in the liver as well as within the endothelial cells. Okay? All right, so now we'll get started with the actual cascade. So the intrinsic pathway, this is activated via contact activation. So contact activation means like you are falling, you're scraping your knee, you have some sort of surgical procedures, but within like where you would need clotting, where there's a breach in the skin barrier, that's contact activation, okay? So there's something actually happening. All right, so we have 12. The first thing that's going to happen is this contact activation is going to basically activate factor 12 to turn into factor 12A, and the A stands for activated, right? So it's like the active form of 12. It's, again, very similar to complement. Except with complement, remember the A was for like the anaphylotoxins, but now it's like, this is the activated form of 12A. And again, like I said, orange, this is created once the pathway got active. That's why it's an orange. 12A is going to go ahead and convert factor 11 to 11A. Okay. 11 is going to convert 9 into 9A, and then 9A is going to convert 8 into 8A. All right, so this is the first step of the intrinsic cascade. The first thing that happens, we got contact activation activating 12, and it's 12, 11, 9, 8. Cool. All right. So that's the intrinsic pathway. Here's the extrinsic pathway. So the extrinsic pathway, same thing. Blue is it's always there. So here's factor 7. It's always there. It's always being made by the liver. And then orange is it's created when the pathway becomes active. So the only thing we have so far is factor 7. So I'm just going to do that one first. So factor 7, its full name is proconvertin, and it is made in the liver, and it is vitamin K dependent. The extrinsic pathway is activated via tissue damage. So this is like, the reason they call it extrinsic is because now it's like, it's not just like exposure, like it's not just now we're bleeding and we need to clot it. It's like now the tissue actually became damaged. A lot of the times you get both at like intrinsic and extrinsic activation at the same time, especially if you fall and scrape your knee, the tissue is going to become damaged, right? But it is important to know which factors are in which pathways for if you have like factor deficiencies, like a factor 8 deficiency, a factor 9, something like that. So it is important to know like which factors are in which pathways, but a lot of the time, just in like life, like understanding like clinical life, these are likely getting activated at the same time. Okay, but they are a little bit different. This tissue damage, it's because damaged tissues secrete tissue factor, which is factor 3, which is not on here yet. Once factor 3 is made by the damaged tissues, now the pathway gets activated. Okay, so that's a little bit different from the intrinsic, but again, a lot of the times they get activated at the same time. Okay, so here's factor 7. It's just hanging out in the liver. It's always made. And then once you have tissue damage, that tissue is going to secrete factor 3. It literally stands for tissue factor, and it's secreted by endothelial cells, which makes sense because endothelial cells make up tissues. So once you have that damage, these endothelial cells secrete tissue factor, and then it activates this pathway. And all that really happens here is factor 3 is going to convert factor 7 into factor 7A. And that's the whole extrinsic pathway. Okay, cool. So now we have the common pathway. So the common pathway is where the intrinsic and extrinsic pathways combine. So we have factor 8A, this was the end of intrinsic, and we have factor 7A, this was the end, quote unquote, of extrinsic. And now basically what happens is they're going to combine and common, like, again, it's kind of like complement. There's a common pathway that, like, not a common pathway, but it was like after you get like the C5 convertase, all the pathways are the same. It's the same here. Okay, so both pathways are the same. Like I said, a lot of the times both of these get activated at the same time. But if you have one, if extrinsic only gets activated, it's going to go through this pathway. If intrinsic only gets activated, it's going to go through this pathway. But what all of these stand for, so we have factor 10. This is Stewart factor. This is probably the one that they ask the most. Just like doing practice questions, they'll bring this one up the most, like the common name of it, Stewart factor. I would remember it, something dumb like Stuart Little was 10 years old, something like that, like something dumb. But that did come up a lot. And it's created in the liver. This is another vitamin K dependent factor. And then you have factor 5. This is proacceleratin made by the liver. Factor 2. So factor 2, there's like factor 2 itself and the activated form of factor 2 have two names. So I put them both here because they just use these interchangeably, especially when you're doing pharm. They'll just like, oh, it inhibits thrombin or it activates thrombin or it does something. That's factor 2A. It's like activated factor 2. So these, I would say factor 2 and factor 1, they usually never call them factor 2 and factor 1. They call them by their full names. So factor 2, normal, is prothrombin. And 2A, the activated form of obviously prothrombin, is thrombin. Also made by the liver, it's vitamin K dependent. And then factor 1 is fibrinogen, and the activated form of factor 1 is fibrin. Like I said, the whole goal of the the coagulation cascade is to get fibrin and then to stabilize it, like to get that cross-linked clot. And then, of course, factor 1 is also produced by the liver. And then lastly, we have factor 13, which is over here, just kind of floating around. This is called fibrin stabilizing factor. It's made by the liver as well as the bone marrow, and this just kind of solidifies our fibrin clot. So we'll go through this, but definitely know these names, especially factor 2 and factor 1. But anyway, so regardless, we came from the intrinsic pathway, we came from the extrinsic pathway. We have 8A, 7A. Either one, both, doesn't matter. They're going to activate factor 10 into 10A. 10A is going to convert factor 5 into 5A, and then 5 is going to basically convert prothrombin into thrombin. Okay, so here's prothrombin into thrombin, and then thrombin is going to both convert fibrinogen into fibrin, as well as activates your fibrin stabilizing factor, so 13 into 13A. And then from here, 13A. So once we have fibrin, this is pretty much like we have like our fibrin clot, right? That's the goal of this pathway, but you need to stabilize it. And that's why this factor got its name, fibrin stabilizing factor. We want to cross-link our fibrin clot. That is like the goal of, this whole pathway. And there are factor 13 deficiencies. They're pretty rare, but basically you don't get a cross-linked fibrin clot, and it kind of presents like a clotting disorder. Okay? So just remember this order. So we have, once we get to the common pathway, it's 10, 5, 2, 1, but 2 is prothrombin, 2A is thrombin, and then thrombin both activates fibrinogen as well as your fibrin stabilizing factor, factor 13. And then once you have your fibrin clot, factor 13 is going, activated factor 13 is going to stabilize it, and that's your cross-linked clot. And then you're good to go. Now we have a nice stable clot, essentially. And then I mentioned this in the first session, the primary hemostasis disorders. But this is basically from Ambos, just like another way to visualize it. It's everything we talked about. But I did mention in the last session that calcium is sometimes referred to as factor 4. So if you ever see factor 4, it's just calcium. They just wanted it to make sense within, like, the coagulation cascade with all the factors. So they're like, there's no factor 4. Let's just call calcium factor 4. So it's just something to keep an eye out for. It's not like we missed a factor. It's just calcium. And then another thing too is you'll sometimes see like phospholipids. Sometimes it's abbreviated PL. These are required. Like, these are absolutely required for you. I know it says here it's only this blue arrow. It is pretty much required for this entire pathway. I know not every single step, but you need both calcium as well as phospholipids for this entire pathway to like function. And again, that's why they call calcium factor 4. But just again, something to keep an eye out for. Okay, so next we're going to talk about protein C, protein S, and antithrombin 3. These aren't really talked about as much, but they really help with understanding certain pathologies that we'll get into towards the end. So protein C and protein S, these are cofactors, and they're cofactors for certain clotting factors, and then antithrombin 3. Basically and I call antithrombin 3 AT3 or AT, and then 3, lines, like Roman numeral 3. But so protein C, protein S, and antithrombin 3, these are all like natural anticoagulants. Okay, so natural. These are ways to kind of slow down the coagulation cascade, just to make sure you're not like clotting too much, right? Because again, even with complement, we had certain regulators of the complement cascade. It's kind of the exact same thing here. These are kind of regulators of the coagulation cascade now, because again, they're physiologic. These are good. Everyone has these, and these are good things. They just kind of make sure it's going at like a normal physiologic rate. It's not doing it too much. It's not too little, like little things like that. But these things slow down the coagulation cascade normally physiologically. These are not given to patients. They're always floating around. They're also made by the liver. So again, these are all proteins. They're all made by the liver. And again, they're regulating coagulation in such a way to make sure you're not overclotting normally on a normal basis. So how do these guys slow down coagulation? So protein C and protein S, sometimes they're asked because these are cofactors, and like just in like true biochem like state, like they'll be like, okay, well, they're cofactors. What are they cofactors for? And these are cofactors for factor, where is it? So factor 5 and 8. So what I didn't put that on here, but basically what they do is they interact with 5 and they interact with 8, so factor 5 and factor 8, and basically don't allow the formation, like the activated forms of each. Okay, so that's kind of what I mean. They inhibit I should really write like technically they're inhibiting the formation of 5A and 8A. Okay, so they're cofactors for 5 and 8, and they're blocking basically the production of 5A and 8A. And sometimes, some questions will get even like trickier and be like, well, what are some really important, clotting factors? And it'd be the ones that, are blocked by these natural circulating anticoagulants. So 5 and 8 are really important, clearly, because they're blocked physiologically. And it's kind of like with the immune system, we know that there's certain things that are important because the immune system is working to block them. It's kind of the same thing here. We know that 5 and 8 are important because there's physiologic proteins that are working to regulate them, I should say, not block, but regulate. Hopefully that makes sense. So protein C, protein S, they're going to be cofactors for factors 5 and 8, and they're not going to allow the formation of 5A and 8A. So they're technically inhibiting 5A and 8A. And then antithrombin 3 basically blocks a lot of the coagulation factors. It does a lot, but the main two and the ones that mostly will come up in questions are it's going to inhibit 10A and 2A. So 10A is activated 10, 2A is going to be, so remember from our little chart, 2A is basically thrombin. So antithrombin 3, right? Antithrombin, it's blocking thrombin. So this is a little different from the cofactors. This is a little different from CNS. This is straight up blocking thrombin. It's just coming over here and it's like, nope, I'm blocking this. Okay, so that's what antithrombin 3 is doing. It's blocking thrombin from doing anything. And it also inhibits 10A up here. Okay, so that's what antithrombin 3 does. Protein CNS work with 5 and 8 to block the activated forms of 5 and 8. Okay. And like I said, antithrombin 3 also, even though it's antithrombin 3 and it does more than just block thrombin, it does 10A and thrombin. It does others. So if you're doing questions and it brings up antithrombin 3 can, block, I don't even know, 8 or 9 or something, like probably. But the main two it's trying to block, obviously from its name, is thrombin as well as 10A. Okay, and you'll see there's a disorder called like antithrombin 3 deficiency, and you'll see like what the main effects are because you're not getting that inhibition of 10A and 2A. Okay, so here is our clotting cascade. So if you kind of think of it in terms of the intrinsic pathway over here and the extrinsic pathway over here, and then they kind of come together in the common pathway over here. And then once you get that strong cross-linking by 13A of your fibrin, that's what gives you your strong clot. Okay, and this is how we're going to kind of go through the whole cascade. And then where factor C and factor S and antithrombin 3 are basically working, like what their goal is they're blocking 8A, 8A here, 5A down here in the common pathway, and then antithrombin 3 is blocking 10A as well as 2A, which is thrombin. Okay? Okay. And then just as a quick side note, this will make sense with something we're going to talk about later, but protein C and protein S, these have the shortest half-lives out of all the coagulation factors. And I know that these are technically not coagulation factors. They're just natural circulating anticoagulants. But if you were to put, protein C, protein S, antithrombin 3, and all the coagulation factors together, these have super short half-lives. And if you're like, cool, why does that matter to me? There's a disorder where it's really important, not even a disorder, it's just like understanding how to administer warfarin. If you understand that CNS have very, very short half-lives compared to all of the coagulation factors, it'll make sense with a certain thing you have to do with warfarin. Okay, and I'll bring this slide up later, but I just wanted to put it in here while we were talking about CNS, protein C and protein S. All right, so test to measure coagulation. So no bleeding time. Bleeding time's out. Bleeding time has absolutely nothing to do with coagulation. Remember, bleeding time is only for platelets, not for coagulation. Don't forget that. They will try to trick you. If you have a prolonged bleeding time, you have a platelet disorder. That's it, right? If you have prolonged PTT, it's going to be a coagulation thing. It's really not going to have anything to do with platelet disorders. There are exceptions, but just really kind of separate the two. Bleeding times for platelets, primary hemostasis, what we talked about last week, and then your PTT is going to be now for secondary hemostasis and stuff like that, your coagulation cascade. So PT-INR and PTT is coagulation. So your PT stands for prothrombin time. Another thing I want to point out is some people just not memorize, but they learn, PT, and then when they're doing questions and they read, prothrombin time, they think this is PTT. And then they get all sorts of messed up. So just really try to remember that PT is prothrombin time. So here's the P, here's the T. And then your PTT, sometimes you'll see it written as APTT. This is like activated partial thromboplastin time, okay? So again, like I said, they might just try to be tricky in vignettes and not give you the word like PT and PTT. They might write the patient's prothrombin time is blank, and you can't do prothrombin time and think it's PTT. You're going to get the question wrong. Okay, so PT, prothrombin time, PTT or APTT, doesn't matter, activated partial thromboplastin time. Okay, and then the other thing too is sometimes they give you an INR. INR is an international normalized ratio. When I was working in a hematology lab, you don't report out a PT ever. You always give the doctor the INR. And all this is it depends on your hospital. So if you're in, let's say my hospital uses a certain reagent to do a PT and you're in a different hospital and there's a different reagent to do a PT. Well, if the patient is going from different hospitals, their PT might be different, from one hospital to the other, because it really depends on the reagent they're using. So people came up with something called an INR, and basically they're standardizing a PT. So no matter what reagent you use, it's going to be you can use this value to compare across all hospitals. Okay, so this is more clinical, something when you're doing, when you're on your rotations and stuff, you'll never tell a doctor what a PT is. You'll always report the INR because that's what they want to know. But for example, I just wanted to mention it now for vignettes if they give you an INR, because sometimes they will to try and make it like clinically relevant. But that's all it is. They take the PT, they run it through a formula, and then it gives them a value. So it doesn't matter what reagent you use. It would be like a standardized value. You can compare hospital to hospital, reagent to reagent. All right, so PT, PTT, I always see different reference ranges. I feel like every single time I go on Amboss, it's a different reference range for the PT and PTT. So I really want to emphasize, like, it's going to vary depending on what site you're using. You know, UWorld might be different from Amboss, might be different from USMLERX, like, just your exam. It just might be different. So use whatever reference range you're given. So really, really, really want to emphasize that whatever reference range you're given with, and of course for your exams, you're given reference ranges. So look at the reference range where you're at. And it's going to be hard too. Like if you're doing UWorld and then when you get to boards, it might be different on boards. So just give it a quick glance, even though if you're like, you know, for sure, like this is the reference range. This was the reference range when I made this PowerPoint with UWorld, right? So just it might be different now if you go on UWorld now. So just something to keep an eye out for. It might be different. So your PT, this is usually it's 11 to 15 seconds, and it's commonly used as a measure of the extrinsic pathway. We already kind of mentioned this. It's normalized between hospitals with your INR. If a patient's on warfarin, their INR reference range is 2 to 3. So again, this is more clinical for fun. And then this is used to measure warfarin. So if a patient is on warfarin, and you just need to monitor how their progress is. You want to make sure that they're not, warfarin's an anticoagulant, right? So we want them to be anticoagulating. We want them to not be clotting as quickly, right? That's the whole point of putting them on an anticoagulant and not clotter. So it's going to be a little bit extended of a reference range, right? Because again, what the PT and the PTT are is time to clot. Like these are time to clot. So the PT is measuring so if we start with the extrinsic pathway, how long is it taking to clot, to get like that fibrin clot at the end? So if you think about it like this is what a PT is measuring. So the extrinsic pathway all the way down to my time to clot. The PTT is measuring this way, the intrinsic pathway and the common pathway like this. Okay? And I also remembered that too, the PT reference range is a lot shorter than the PTT reference range because of this, because it's like, look how many factors you have to go through with the intrinsic compared to the extrinsic. So it's a little bit longer of a reference range, even though both do test the common pathway. The PTT is used really for the intrinsic pathway, PT is used for the extrinsic pathway. And then the other thing too that you use this for clinically is just measuring warfarin. So if they patients on warfarin, they're like, okay, you need to measure just to monitor like how their warfarin progress is or their Coumadin progress, same thing. You usually will do a PT. Okay. And we'll talk about this a little bit more. I go into warfarin and heparin today, so we'll go into it a little bit more. But usually, again, like I said, if you're doing vignettes, which you probably are going to start doing soon, like you're going to start doing questions, and they tell you the patient's on warfarin, they might say they might just give you a PT because that's how you measure warfarin with. Versus a PTT, this reference range is longer. Like I said, it's used to measure the intrinsic pathway. And like I said, this is extrinsic plus common because the common pathway is included within the extrinsic and within the intrinsic. But I just mean very specifically, the PTT measures the intrinsic pathway down to the common, and the extrinsic measures just the extrinsic all the way down to that fibrin clot through the common. And then the PTT is used to measure heparin. Okay. And again, I sometimes get asked, well, why is it PT for warfarin and why is it PTT for heparin? And honestly, it's just that's just what they do. That's just what they decided to do. That's what they do. I think with warfarin, and like I said, we're going to talk about warfarin, and it's a scary drug. It's basically rat poison. That's what warfarin is. So I think they wanted a test that was just going to be quicker, right? They'll know if it's working because it's 15 seconds, and then they'll know if the patient is clotting properly, if it's too much or too little or whatever. So I think that's the only reason they picked a PT for warfarin. Okay. So interpretation. So this is usually where this is when you're doing practice questions, this is what they'll get you for these secondary hemostasis disorders. They'll give you PT and PTT values, and then you have to interpret that. So like I said, PT is for your extrinsic pathway, PTT is for the intrinsic pathway. And then, the common pathway, both are included, obviously. The common pathway is included in both a PT and a PTT. So if you think about it, and like I said, this is time to clotting, right? So it should take, in theory, a PT, it should take 11 to 15 seconds to go through the entire extrinsic pathway, the common pathway, and get a clot. So if you have a prolonged PT, a prolonged prothrombin time, that means it is taking a longer time to clot. So this is where I just mentioned right now, like I'm just mentioning, there's something wrong with, so if the PT is prolonged, but the PTT is normal, this can only be an extrinsic pathway problem, right? Because the common pathway is in both. So if something wrong with the common pathway, both of these would be prolonged because both measure the common pathway. But the only thing the PT looks at that the PTT doesn't is things only in the extrinsic pathway, which is only factor 3 and factor 7. Okay? So I'm just going to mention that now. Something is wrong with factors 3 and factor 7, so it's not able to clot within that 11 to 15 second time frame. Conversely, you have a prolonged PTT, but the PT is normal. Now it's like, okay, common pathway's fine because both are measured with a PT and a PTT. The only thing that the PTT measures that the PT doesn't is the intrinsic pathway. So that's 12, 11, 9, and 8. So there's something wrong with one of these 4 factors, 12, 11, 9, and 8. All the other factors are probably fine. And then I put this nice little asterisk and I highlighted it because this is what I mentioned in the primary hemostasis talk last week, is remember, depending on, so we talked about with von Willebrand disease, if you have von Willebrand disease and you're missing von Willebrand factor like severely, you have a severe deficiency, not even a severe deficiency, but you do have a deficiency in von Willebrand factor. Von Willebrand factor combines with factor 8, they work with each other to like make each other work properly. So what that means is if you don't have von Willebrand factor because you have this platelet disorder, you have von Willebrand disease, or you have something happen where von Willebrand factor is down, your factor 8 is not going to work properly. And now there's nothing wrong with factor 8, it's there, but it just can't work properly because it doesn't have its cofactor. It doesn't have von Willebrand factor because of that primary hemostasis disorder. Now you can have a prolonged PTT. And this is what I was pointing out. We did that question together last week, in the last one as well. You can have a platelet disorder and the vignette sounds like it's a platelet disorder, but now the PTT is prolonged. Don't immediately assume if the PTT is prolonged that it's going to be this factor 12, 11, 9, and 8 issue. Like it's a 12, 11, 9, and 8 issue. It could be a platelet issue, but here's my little asterisk. It could be, but really only if it's like a von Willebrand factor thing and factor 8. Okay, so I just wanted to put this here as like a reminder. Like we did talk about it last time. You can have a platelet issue that can prolong the PTT. So, but the other way to kind of tell like if this is happening is what's the bleeding time? The bleeding time should be also prolonged if it's a platelet issue. And if you remember from doing that question in the primary hemostasis disorder question PowerPoint, the bleeding time was prolonged, and that's how you know for sure like this is a platelet thing. So you can actually, even though PTT is prolonged, bleeding time is prolonged, we can actually cross out like a factor 8 deficiency or something like that. We can cross out a secondary hemostasis disorder because there shouldn't be any secondary hemostasis disorder that affects the bleeding time, but there can be primary hemostasis disorders that affect the coagulation tests, these PT and PTTs. Okay. Really want to emphasize that because that's like the trickiest question you would see. So if you can remember that, that's like as tricky as it would get for like at least for your exam. Okay, and then let's say both are prolonged. So let's say your PT is prolonged and your PTT is prolonged. Well, it's got to be something that's measured by both of these tests. So it's got to be something in that common pathway. So something is wrong with one of these 4 factors. So 10, 5, 2, or 1, also including, thrombin as well as prothrombin, thrombin, fibrinogen, fibrin. PT, PTT, nothing to do with platelets. Nothing. The only thing, again, PTT can be prolonged with a platelet disorder, but again, look at the bleeding time. That'll tell you, like, yes, this is a platelet disorder, or no, like, this is a primary hemostasis disorder, or this is not. All right. So now some pharm. So we're going to do warfarin and heparin today. So warfarin, the other name for it is Coumadin. You can see these interchangeably. It's given orally. So a lot of the times with farm, I know you really haven't had like true farm questions yet. I know that they started to implement them during first year, which is great. But a lot of the times farm is asked a lot during second year. Know both names for like all of the drugs. Know, routes of administration, how they work, what's their mechanism of action, and then like any weird side effects. So that's what I always try to, when I'm going through farm stuff, that's what I always try to put at the forefront. So Warfarin or Coumadin, given orally. So it's a tablet. You can see here in this picture, it's a pill. You just give it to the patient. It really is a rat poison. It's like literally they give this to rats to kill them. They die by bleeding. So bleeding is how they die. So how warfarin works, and again, this is really important to understand for some of the pathology we're going to be talking about, is it's going to physically go, and I know it doesn't go, but like it's going to imagine warfarin working its way through the blood. It physically goes to the liver and blocks new production. So new production of those vitamin K dependent factors. So like I said in that chart, I had some that said liver, and then in parentheses I had vitamin K. There's 4, 2, 7, 9, and 10. And I even think Dr. Zatar is like, just you can remember this by 2 plus 7 is 9, and then 1 more is 10. Whatever you need to do, know this. But definitely know that 2, 7, 9, and 10, so factor 2, 7, 9, and 10 are vitamin K dependent. And that's what warfarin is blocking. It basically stops vitamin K from allowing the production of these factors. But it's really important to understand it's new production. You can have all the 2, 7, 9, and 10 around. You can take warfarin. It's not going to block the ones that are already there and made. Those are there. You kind of have to just wait for them to, get converted, go through that whole pathway. All right. But new production. So imagine like it literally goes to that enzyme. So basically what it's doing is it's inhibiting gamma carboxylation. I highlighted this because this is its mechanism of action. So it does get asked. Mechanism tends to get asked a lot with farm. So imagine it goes to the liver and it finds the enzyme that makes new factor 2, new factor 7, 9, and 10, and it blocks this process of gamma carboxylation. And then I forget what the symbol is. That might be gamma. I already forget. I don't think that's gamma. But know the Roman numeral. That's not the Greek letter. Actually, I actually don't remember. But know what the the Greek letter is for gamma carboxylation. I actually have seen questions where they don't write gamma carboxylation, they put the Greek like symbol for gamma, this is not it. I'm just forgetting what it is. But look that up and remember that, because you'll see that like on vignette questions and like the answer choices. But it's blocking this enzymatic process. So the factors that are there. So 2, 7, 9, and 10 are there. They're going to still work for a little bit, but you won't get any like replenishment of those factors. And like I said, the thing to remember with these zymogens is that these are constantly being made. They're not getting made once you have like bleeding. That would take forever. That's why zymogen pathways like evolutionarily exist. So they're already there, and then things activate their cleavage. So the liver is just churning them out always. So you're not going to get new churning out, which is not good because we need them to already be there. But that's how warfarin works, we're not allowing the formation of these new factors. You're not basically allowing for the formation of a clot. Okay? Because you need these for, intrinsic pathway, extrinsic pathway. It hits all the bases. Intrinsic, extrinsic, and common. It hits all of them. All right, so it does those factors. It does 2, 7, 9, and 10. It also does protein C, and it also does protein S. And remember, protein C and protein S, it's going to block new production of these guys as well. And these guys are also made in the liver, and they're acting as cofactors for factors 5 and factor 8. I know there's a lot to remember, a lot of factor things to remember. But basically, warfarin blocks vitamin K dependent factors 2, 7, 9, and 10. As well as protein C and protein S, and protein C and protein S. These are cofactors for factors 5 and factor 8. Or it's like, it's working with the cofactors 5 and 8. Yeah. It's not, so you're blocking a lot of stuff with warfarin. That's why, like I said, this is a very potent anticoagulant, and that's why they give it to rats to kill them. But here's this one bullet point. This is a lot of the stuff they could essentially ask you about warfarin. You got its mechanism and kind of like how it works, but I'm really emphasizing this for when we talk about warfarin heparin bridging in a few slides. So when you put a patient on warfarin, and this is good clinically, this is good for exams, like your board stuff, you need to start the patient on heparin at the same time. You have to. So you start the patient on warfarin for a short period of time. You also give them heparin. All right. This process is called warfarin heparin bridging, and I'm going to go into it, but it will not make sense why you bridge. Like, why do you bridge if you don't understand how it's working? It's blocking that new production of 2, 7, 9, and 10 protein C and protein S. Actually, my big, she's a second year resident now, and she just said like she got in a huge fight with one of the like new interns because they put him on warfarin without heparin, and she's like, you didn't bridge. Like, why didn't you bridge? It's like a very, and like the attending got really mad at the intern. It's a thing. So like she's like, and I'm like, oh, I'll have to mention that in like the tutoring sessions, because she's like, yeah, it was a whole big thing that the intern didn't bridge. They got in a lot of trouble. So whenever you start a patient on warfarin, you have to bridge with heparin, and it'll make sense. I'll go into it. And then again, warfarin is usually monitored by a PT. Like I said, I think the reason why is because they just want, like, because this is such an intense drug, they just really wanted, like, the quicker of the two tests for monitoring. So it's like, okay, PT, you should get an answer within 11 to 15 seconds. PTT is like 25 to 40 seconds. So like, let's choose to use a PT to monitor warfarin. But like I said, 2, 7, 9, and 10, PT measures extrinsic pathway, right? So extrinsic pathway is 3, 7, and then 10, 5, 2, and 1, right? That's the extrinsic pathway. But look what warfarin's blocking. It's blocking 7, right, which is in the extrinsic, but it's also blocking 9, which is in the intrinsic, and it's blocking 2 and 10, which is in the common. So technically, the PT is also going to be prolonged. And it is I know that this sounds very intuitive, but it is unreal how many of my classmates, how many of the kids that I tutored, and I tell them, like, look out for this, they're going to do this, and you're going to get tricked, you're going to get got. Don't get got, because it just sounds so intuitive, but it's something people forget. Your PTT is also obviously going to be prolonged if you're on warfarin. But just, I think everyone associates a PT with warfarin, and they just think, like, the PTT is normal. PTT is not normal. Both of these are going to be prolonged. Okay, so I just wanted to throw that on here because it happens every single year. People are like, oh, you said that. And I'm like, yeah, nah, it happens. But don't let it happen. Okay, and then the other thing, if you accidentally OD, like let's say you take too much warfarin, this is very bad, because there's really no way to stop the process from happening, right? Because think about it, warfarin is not blocking, it's not inhibiting the factors already there. It's not even letting the liver make new clotting factors. So how do you reverse that? Like, how do you reverse them not making something, essentially, right? So I put, like, you have to physically wait now for the liver to make more clotting. So again, if you OD on warfarin, you're really, like, never going to make more 2, 7, 9, 10 protein C, protein S. So think about, like, how would you reverse something like this? You just give something that has tons of clotting factors. Tons. So one of the things that has a lot of clotting factors that's like available in the clinical lab is fresh frozen plasma. So it's called FFP. There's tons of fresh frozen, like when they do, in the blood bank lab, they have fresh frozen plasma. You thaw that, you give it to the patient. Even cryoprecipitate has a ton of clotting factors. But either one, there's just something with tons of clotting factors. You can just transfuse it into the patient, then it'll act like there's clotting factors there, right? So that's one way to kind of, you can't block, like you can't reverse warfarin, but you can like reverse the effects of warfarin by just giving clotting factors, okay? And then the other thing that you can give is vitamin K, right? I mean, it blocks vitamin K dependent factors. So it basically, this process of gamma carboxylation needs vitamin K. So you can just give vitamin K. It's like, here you go, here's vitamin K. However, this is a lot slower. It takes a lot, like, it's slower to kind of replenish the 2, 7, 9, and 10 if you do this. So a lot of the times what like doctors will give this FFP or even cryoprecipitate, something like that. Just something with clotting factors, and then, you can think of, but you can give vitamin K in theory, it's just they don't do it usually. But hopefully that makes sense, because it's like, it's blocking vitamin K, like the vitamin K factors, so just give vitamin K. Okay, and then the last thing is here I'm introducing with the farm now, my teratogen tarantula. So I do have it, just like Sketchy, I have a teratogen tarantula. Warfarin is a teratogen. This is good to like, it's honestly good to start like keeping like a chart or like a list somewhere as you're doing Sketchy farm and know what all the teratogens are. Because like, especially on Comlex, the amount of questions where they ask like, they give you a prompt with a pregnant mom. And in theory, a lot of the drugs could work. It's like, okay, what drug should we give to this mom, this pregnant woman? in theory, like 4 of the drugs can work, but 3 of the 4 are teratogens. So it's like very good to know which ones are, you can't give teratogens to pregnant women. You can give them to other people. You can't give them to pregnant moms. So teratogens cross, that means that warfarin can essentially cross the placenta and then it can go and attack the developing fetus. Okay. And then sometimes what they'll also ask on boards, at least on boards, is, you give warfarin to a pregnant mom. Oops, accident. You give warfarin to a pregnant mom. Baby's born. What happens to the baby? Like how did that affect the baby? And warfarin, its birth defect is abnormal bone formation. So it can cross the placenta and actually form bone. Like it can actually make bone not form correctly. Okay, so sometimes they'll ask that as well. It's like, oh, you did give warfarin to a pregnant woman. What happens? Like, how's the fetus? Like, what's happening to the fetus in utero now? Okay, cool. All right, and then here's heparin. So heparin, its mechanism is kind of weird. It's kind of odd, to be honest. Basically, what it's doing is this is like the best, simplest way I can think of how I explain heparin to people. It speeds up the natural ability of antithrombin 3 to inhibit 10A and 2A. Okay, so if you think about it, basically all it's doing is it's making antithrombin 3 better at being antithrombin 3. So it almost like enhances antithrombin, and that's its whole mechanism, which is, I think it's hilarious that its mechanism is to make something physiologic just work better, right? So heparin speeds up the natural ability of antithrombin 3 to do what antithrombin 3 does, which is inhibit 10A and 2A, which is thrombin. But why this is such a great drug is that it is super, super fast acting. So it does not have to inhibit any factors. All you're doing is you're making antithrombin 3 more potent. That's why it works so quickly. That's why, like, if you're in the hospital, patients get heparin. And the other thing, though, with heparin is it's given IV. So this is an IV. It's like an injection through, like, an IV. So usually this is for inpatients. You really can't do heparin outpatient. There are some... they're called like low molecular weight heparins. You can give those orally, but this I'm speaking strictly about IV heparin because that's what I wanted to talk about today with like the bridging, like the warfarin heparin bridging. IV heparin is like every single doctor like gives it. They always put their patients on a heparin drip for anticoagulation because again, all it's doing is it's making something physiologic better. We're not inhibiting anything. We're really not, we're not inhibiting the formation of factors. We're not messing with anything. We're just making antithrombin 3 more potent, so to speak. That's why it works so quickly. This is the anticoagulant of choice. If you think a patient's having a myocardial infarction, if you think a patient's having a heart attack, they'll literally put them on heparin. They're like, okay, let's put them on heparin because it works so fast. They'll also do like aspirin and stuff, but like heparin is like the anticoagulant, at least, not like... Nothing to do with platelets, not the antiplatelet, just the anticoagulant of choice is always going to be heparin for a patient with a suspected heart attack. You monitor with a PTT. Like I said, this is just, warfarin gets the PT, heparin gets the PTT. But it's the same as with warfarin. The PT is also going to be prolonged because we're inhibiting 10A and 2A. And remember, 10A and 2A, these are both in the common pathway. So they will also, come up in the PT as well as the PTT. Okay, anything in the common pathway comes up in both. So again, like I said, you monitor heparin with the PTT, but again, don't get got on your exam. The PT will also be prolonged. Okay. For this, if a patient ODs on heparin, and I say OD, I mean they're just taking too much. Like you're taking too much heparin, you're like, oh no, I don't want them to bleed out. So what can you give now? With warfarin, you give fresh frozen plasma, cryoprecipitate, vitamin K. You give them things to replenish the factors. With heparin, there's actually an antidote. It's protamine sulfate. So protamine sulfate, it basically, I think Sketchy goes into it. It just binds up all the heparin that's in the blood. It just goes to the blood. It finds it. It binds it up, and it makes it stop working essentially. But definitely know that antidote because you can very easily, since it's IV and it works fast, it's really easy to give too much. So it's good to know that there is an antidote, so to speak. You give protamine sulfate. And then a quick tie-in before we talk about some warfarin heparin bridging is antithrombin 3 deficiency. So an antithrombin 3 deficiency is a patient does not have antithrombin 3 or they have a deficient amount of antithrombin 3. And remember, antithrombin 3, this is your natural circulating anticoagulant that inhibits 10A and 2A just naturally, physiologically. Heparin makes this work better. So my thing here is you should really think about an antithrombin 3 deficiency if you're doing questions, you're reading vignettes, and you basically start a patient on heparin and nothing happens to their PTT, which again, you're trying, right? We're trying to stop clotting. Like we are trying to make a PTT longer than 25 to 40 seconds because we want to block clotting. And PTT measures time to clotting from the intrinsic pathway down to all the way down to a fibrin clot. So if you give heparin and nothing happens, it's still, 30 seconds, you're like, that's weird. But that's when you should start thinking of an antithrombin 3 deficiency because that's how heparin works. That's heparin's mechanism of action, is to make antithrombin 3 work better. All right. And then the prompt may also mention a patient having a history of clotting. So, they have like lots of DVTs, they have a lot of PEs, clotting, they just mention that there's clotting issues that like they've experienced throughout their life. But this is always the key. You start a patient on heparin and the PTT stays exactly the same. That you're like, yeah, that's antithrombin 3 deficiency. And I'm going to go through it to kind of like help visualize it. But so here's like our normal pathway. So here's our intrinsic pathway, extrinsic pathway, common pathway. And again, here's where antithrombin 3 works. So antithrombin 3 basically is going to slow down the clotting cascade. It's a natural anticoagulant. And it's going to basically block activated factor 10 and activated factor 2, which is thrombin. So it kind of blocks these. And like I said, it does a lot of other stuff. So if you're doing questions and like, it also inhibits 8, it probably does, honestly. But the main two is obviously thrombin, it's antithrombin. So it like very much is trying to block thrombin, and 10A also, it also gets blocked pretty well with antithrombin 3. But I just wanted to just cover all the bases. It definitely can block more than just these two, but these are the two main ones. All right, so this is a normal person. So normal person, we just don't want the clotting cascade to be going through too quickly if it doesn't need to. So it's kind of acting as like little block, like it's kind of trying to slow down this clotting cascade a little bit. So now, and then you don't get, again, if there's nothing to clot, if there's no reason we should have a clot, you shouldn't get a clot. That's the whole point of like, protein C, protein S, and antithrombin 3. We don't want a clot if there shouldn't be a clot there. So now, let's say we have antithrombin 3 deficiency. So now we have an antithrombin 3 deficiency. So what happens here? We don't have blockage of 10A and 2A. So now it's almost like normally the common pathway can be going through quicker than it should be, and you're getting basically more of a clot. And this is what's known as, the patient is now known as being hypercoagulable. And that's why like certain vignettes might even mention, patient has a lot of DVTs or PEs because they're making more clots than the normal person because there's nothing kind of stopping the formation of like rogue clots, essentially. All right, so here's heparin. So now let's think about why when a PTT prolong with heparin, if you have an antithrombin 3 deficiency, normally what heparin does is, here's antithrombin 3 doing what it does. Heparin basically makes them bigger. So it's really making antithrombin 3 good at its job. So it's really, really blocking this clot. You're really getting blockage of like a nice strong clot. It's like, nope, we're not getting a clot today. But now let's imagine you have heparin and an antithrombin 3 deficiency. So now there's no antithrombin 3 here. You give heparin, nothing happens. It's like, nice, cool, nothing, because there's nothing for heparin to do. So that's why, your PTT won't prolong, which again, you want the PTT to prolong with heparin. You're trying to prolong the time to clot with heparin because we're giving anticoagulation. We want anticoagulation. All right, cool. So now the warfarin heparin bridging. So like I said, this just came up with my big like last week in her in her residency. So again, this terminology, warfarin heparin bridging, is a patient started on warfarin has to also be started on heparin at the same time, just for a little bit until warfarin kicks in all the way. All right, so you have to make a bridge between warfarin and heparin until warfarin can really start working, and then you can kind of take the patient off heparin and allow them to stay on their warfarin. And what this kind of comes down to is back to this idea. So remember that protein C and protein S have the shortest half-lives out of all of so if you compare protein C and protein S to all the other coagulation factors, these guys have the shortest half-lives, okay? And then recall that warfarin is going to inhibit all the vitamin K dependent factors, which are 2, 7, 9, and 10, as well as protein C and protein S. All right. So this is the best way I can explain warfarin heparin bridging. So here's warfarin. I drew a rat because it's rat poison, right? So as a reminder, protein C and protein S are basically inhibiting the formation of factors 5A as well as factor 8A. Okay, so here's 8A up here that it's blocking, and then here's 5A down here that C and S are blocking. So what happens is warfarin is going to go to the liver, right? So remember, it's not knocking these off right away. It goes to the liver. It actually doesn't do anything to these guys yet. It goes to the liver, and it's like, hey, I need to stop new production of factors 2, 7, 9, 10, protein C and protein S. I don't need any more of those being made. But like I said, protein C and protein S have super, super, super short half-lives. So when these guys are circulating around, where's 7? So here's 7, here's 2, so 2, 7, here's 9, and here's 10 down here. So these are all the factors that warfarin is going to eventually, it's going to inhibit. So these guys are all floating around. If they're not replenished, eventually they're going to die off, right? Because nothing lives forever, right? Especially not the clotting factors. These guys don't live forever. So CNS have the shortest half-lives. So when they're just out and about in the blood, they're going to die off first, so to speak, because they have such short half-lives that if they're not being replenished by the liver, there's nothing there anymore. Okay, so that's what I mean by half-life. It's the ones that are already out and about, they die off. Okay, so back here, so warfarin goes to the liver, and it's going to inhibit new production of factors 2, 7, 9, and 10, protein C and protein S. Since protein C and protein S have short half-lives, the pre-existing ones, these guys, the pre-existing ones out in the blood, are the first ones to die off. So out of 2, 7, 9, and 10, C and S are the first ones to die off. Okay? So let's say that's what's going to happen. So we give the patient warfarin. Here it is. It knocks, basically, and again, this is not actually what's happening. Remember, it goes to the liver, but it's just for animation, just for fun. But you give the patient warfarin, and imagine now, let's say, CNS are going to die off super, super quick because they're not getting now replenished by the liver because warfarin went to the liver and it blocked new production of protein C and protein S. All right, so now they're gone. So by protein C, protein S, not here anymore. So factors 2, 7, 9, and 10, they have longer half-lives. So they're still there. So protein C and protein S are gone, but 2, 7, 9, and 10 are still there because their half-lives are a little bit longer than protein C and protein S. So right here, at this time frame, when protein C and protein S have died off, they're gone, now it's almost like the coagulation cascade is accelerated because we don't have 2 out of the 3 natural anticoagulants. So our 3 natural anticoagulants are protein C, protein S, antithrombin 3. We don't have protein C, we don't have protein S. So it's kind of like this one time period where protein C and protein S have kind of died off. Now we're almost hypercoagulable in this spot right now. Okay? So if you think about it, if you don't give heparin at this point, so if you don't bridge with heparin at this point, because now the coagulation cascade is now accelerated a little bit because there's no protein C and protein S, and 2, 7, 9, and 10 are still there, you can cause what's known as Warfarin Skin Necrosis. So this is a pathology state that comes up kind of frequently because it has you kind of have to understand farm physiology. There's a lot to tie in with this. But basically that's what happens. Warfarin skin necrosis is you give a patient warfarin without heparin. So you don't bridge. And again, this is what that attending was on my Biggs intern about. It was how do you not bridge when you start a patient on warfarin? That's that's 101, farm 101. So you give warfarin, you don't give heparin, you're not bridging. You can cause warfarin skin necrosis, which is essentially what it is over-clotting to the point of necrosis. Because you knocked off protein C and protein S before you're truly before you truly get that anticoagulant effect. But if you bridge, you can prevent this. So kind of the same idea. Here's our 3 natural anticoagulants. We have protein C, protein S, and antithrombin 3. So I drew a tree. Well, I gave a tree as heparin because I think that's the sketchy for heparin is you're in a forest or something. I don't know. But I always think of a tree for heparin. So you give warfarin. Here we go. Here's warfarin. Remember, like I said, first thing that happens, CNS are going to die out. Bye. So they go away. Now what you can do is you give them warfarin, you give them heparin, right? So you do an IV infusion of heparin. So this time period where I know we still have antithrombin 3 kind of doing its thing, but you just knocked out 2 out of the 3 natural anticoagulants. So even though this is here, it can't really like compensate. It can't compensate for losing 2 additional natural anticoagulants. And now the coagulation cascade is sped up a little bit. So what this heparin, what giving heparin does is you're making antithrombin 3, you're essentially trying to causing antithrombin 3 to compensate for the CNS until eventually 2, 7, 9, and 10 can die off. Okay? Does that make sense? This is always, people always are kind of confused with bridging, Warfarin Skin Necrosis, but it really has to do with understanding that protein C and protein S have very short half-lives. So, and like understanding that warfarin does not block the ones already there. It goes to the liver and it blocks new production of those. So CNS die off and then you get necrosis because you're speeding up the coagulation cascade. But if you give heparin, you cause antithrombin 3 to like just become better. Now you can compensate until these guys can get knocked out, 2, 7, 9, and 10. Until these guys get knocked out, and then now you have that anticoagulation effect. You can take the patient off heparin, and now you're good. All right? Cool. All right. And then finally, the secondary hemostasis disorders. So here's some of the pathology states that come up with secondary hemostasis. So anything we went through, Bernard-Solier, Glanzmann's, von Willebrand disease last time. Now this is going to be more anything really having to do with the clotting cascade. So the first pathology is liver disease, cirrhosis. I mentioned this in the beginning. All of the clotting factors are made in the liver. Protein C is made in the liver. Protein S is made in the liver. Antithrombin 3 is made in the liver. Mostly, not every single one, but mostly every single clotting factor is made in the liver. Refer back to that chart. So like I said, sometimes a quick way, and I'm not saying this is always done, but I even remember in PBL cases, like my second year, people would be like, you want to just do like a quick PTT to see if the patient's liver is fine. Like we'd be in GI block. We know it's not a hematology disorder, but we'd be like, let's just check the PTT really quick. Let's see how the liver's doing. Because, like, if the liver's really sick, like, to the point of, like, cirrhosis or even hepatitis, something where it's, like, it's really sick, it's not making proteins. So that's, like, a quick way you can do a PTT to see, like, are there even clotting factors being made? Has nothing to do with, like, a factor deficiency. It's just the liver physically is not making them because it's, like, the liver's like, I can't make any proteins. I'm sorry. So that's the first kind of, non-hematology related pathology that can still come up. The next one is if you're vitamin K deficient. So 2, 7, 9, and 10, protein C, protein S, they all need vitamin K to be made by the liver. So you can just not have vitamin K deficient. Now it's essentially like you're on warfarin, right? Like it's like you don't have vitamin K. It's that's what warfarin's doing. It's blocking, the enzyme from using vitamin K to make 2, 7, 9, and 10 protein C, protein S. Or you can just be vitamin K deficient. So think like malnourished patients. Sometimes they'll mention this as like alcoholics. A lot of the times when vignettes mention alcoholics, they want you to think like, malnourishment, like folate deficiency, things like that. They want you to think of like malnourished to the point where you're not even getting vitamin K. Newborn babies are vitamin K deficient. And then throw back to immuno where I mentioned that, remember, all newborn babies get a vitamin K shot. And I think there was like, little vignettes where it's like it's like little vignettes where it's like a mom doesn't go to the hospital. She wants to do like a natural birth. And now the baby's like dying or something like, sorry, but it's like something like that. And it's like, you need to give that baby a vitamin K shot because they can't make vitamin K yet. And as another reminder, the flora, your flora makes your bacterial flora makes vitamin K, and newborn babies don't have their own flora yet. And that's why they're vitamin K deficient. Similarly, if you're on a ton of antibiotics, this isn't as intuitive, but if you're on tons of antibiotics, not even tons of antibiotics, just like on an antibiotic for a really long time, there's certain things you can think of. There's certain like bacterial infections you can think of, but you might also be vitamin K deficient, which is kind of shocking. But if you're in the ICU and you're like on antibiotics for like 90 straight days and now you're like PT and PTTs are starting to prolong and you're like, what is happening? It could just be you're accidentally making the patient vitamin K deficient. Just little things that aren't like as intuitive for like hematology to like think about why like our PTT would be prolonged. And then now more of like the truly hypercoagulable states. Now it's like more of the block relevant stuff. So cancers in pregnancy, you're just hypercoagulable. You tend to just be hypercoagulable with pregnancy. They think it has to do with estrogen. That's why a lot of the times with like especially in like your third trimester that you're like not allowed to fly on airplanes, because it's like the likelihood that you'll get a blood clot is so high because you're just hypercoagulable when you're pregnant. Cancers tend to also make you hypercoagulable. If you have a protein C, protein S, or antithrombin 3 deficiency, that's also, you're considered hypercoagulable. And then another thing we didn't really touch on, but I think I have a slide on it. If you have factor V Leiden, which is actually very common. I know not a decent amount of people, but I know some people that have factor V Leiden, or what's known as APC resistance. This is activated protein C. So you can have factor V Leiden, APC resistance, and then the more common ones for this block, hemophilia A, B, and C. So we'll quickly go through those. So here's factor V Leiden and APC resistance. So normally what happens is once protein C gets activated, it's silly. It's basically just protein C. But once, like we talked about this already, right? Protein C and protein S inhibit factor V, factor V A and 8A. But if you have factor V Leiden, it's basically like you don't, like factor V is, well, I'll just go through the slide. All right. So normally activated protein C inhibits factor V. We talked about that. CNS, 5A, 8A. So it does do this. It inhibits factor V and doesn't allow the formation of factor Va. There exists a mutation in factor V. It's called factor V Leiden. So factor V Leiden, this is the mutation on factor V. I think this is the guy that discovered it. He discovered the mutation, wanted to name it after himself, of course. So this is a mutation where now here comes protein C and it can't inactivate factor V. So you still get factor Va. So now imagine it's kind of like the same idea as having like an antithrombin 3 deficiency. You're hypercoagulable because now it's almost as if protein C is not there anymore because it's not doing one of the things that it's supposed to be doing. So like there's like mini it's not like terrible, but there's like mini hypercoagulability. All right. So, and this is, like I said, this is like if you have it, like likely one of your kids is going to have it. I don't remember what this mutation is. You can do a quick Google search. I'll actually put this in here. at the end before I send it or upload it. But if I had to guess, I would say this is autosomal dominant because likely it's like if the dad has it, the daughter has it, the grandkid's going to have it or whatever. And then this is going to lead to a familial hypercoagulability, like I said. All right. And then lastly, we have the hemophilia. So hemophilia, you can have A, B, and C. Definitely know, hemophilia A is a deficiency of factor 8, hemophilia B is a deficiency of factor 9, and hemophilia C is a deficiency of factor 11. All right. So we have 8, 9, and 11. So with this, here's a pedigree. So we love pedigrees. So it's X-linked recessive. So with X-linked recessive, we did autosomal dominant last week and we did autosomal recessive last week. We didn't do X-linked recessive. But remember with X-linked recessive, it's usually only in boys. And the reason why is because boys only have one X chromosome and then they have a Y chromosome. Girls have 2 X chromosomes. So like let's say, the hemophilia A is, and it's recessive, so you need both bad copies for you to have an effect. So with girls, there's 2 X chromosomes. So let's say this one is affected. I'll draw let's say it's hemophilia A. So I'll draw like an 8. So now we have one X chromosome that has the deficiency of factor 8. Doesn't matter because the other one takes over. It doesn't present. You need both X chromosomes to have the deficiency on it to get it, and it's really not common at all in girls for this to happen in girls. I would even venture to say, especially for boards, you're not going to see it. I'm not going to say nothing's impossible, but you're usually not going to see it. Usually you're going to only get one bad copy from either mom or dad because one comes from mom, one comes from dad. This would have to be like dad has hemophilia A, so he gives you one of the X chromosomes, and then mom had she was carrying the gene for hemophilia. That's so rare. And then she gave you the one of the 2 this is very rare. I don't think they would ever trick you and do this on boards ever. It's just not common. You just won't see it in life. So I don't think they would do that. But that's why girls with X-linked recessive diseases, girls tend to never get them. And when you're doing vignette questions, that's why I say, like, look if it's a male or a female in the vignette, because that can kind of help you, especially with like something like X-linked recessive, where you need both bad copies of it. But with boys, there's only one X chromosome. So if the gene's there, it's presenting. And that's why if you look at pedigrees for X-linked recessive, it's usually only males that have the disorder. So here's your pedigree. Like I said, it's recessive. So remember, anything recessive, it doesn't have to be present in every single generation. So like in this generation, no one, like it's not here. It's just not here. But mom, what happened here is mom's probably a carrier for it. So like, let's say here's X8 and then this one's normal. Because mom doesn't have it. She's not shaded in, but she's carrying it. She probably gave this X chromosome to her son, and then dad gave the Y chromosome to him. And now that's why he has it. This daughter might have it. She might have also given, the bad one to the daughter, but it doesn't matter because dad gave his unaffected X to her and now she's fine. Does that make sense? So look with recessive. Recessive, it's not going to be present in every generation, but if you're looking at a pedigree like this and it's only males that are affected, it's good to think like this is probably X-linked recessive. Another thing to look out for is like, do all the males in one generation have it? That's also like another indication that it's like a recessive trait. Same with this. So this is not all the males in one generation have it. It's likely a recessive trait, but it probably is X-linked because, it's all of the males and none of the females. But again, it can skip entire generations. That's totally fine. That's the whole point of a recessive trait. Okay, and then the other thing to look out for, and like I gave you some questions at the end you guys can do, but look for like bleeding problem in my maternal uncle. And maternal uncle, the whole clue with a maternal uncle is the uncle is affected, so he has the bad chromosome. So the mom, she might be a carrier because they had to have gotten it from somewhere. The uncle got it from one of the two parents, right? So that means the mom likely she's carrying one, and that's why like her son could have it. So like the son could say in the vignette, there are bleeding problems in like my maternal uncle. Like they love to say this with X-linked recessive. All right, but hemophilia A, factor 8 deficiency, B, factor 9 deficiency, C, factor 11 deficiency. And kind of how you do these is you do like, you do a PTT, one will be prolonged, the other will be totally normal. So you can kind of pinpoint what factor it is, or in the case of, so these are all going to be intrinsic within the intrinsic pathway. So the PTT would be prolonged, but the PT would be normal for all of these hemophilias. And then what you do is you basically do like factor studies where you try and pinpoint the exact factor. But again, that's all in the questions at the end. You can kind of work through these and see how they'll ask about it. And then finally, I have my primary versus secondary hemostasis buzzwords. This was what I was mentioning in the last session. I was mentioning how, like I said, they're gonna not try and trick you, but there's going to be at least some overlap. We did do overlap. There was some overlap with the last one. I showed you the von Willebrand disease question, but it had a prolonged PTT. So when things like that happen, just really kind of think about like, what does this sound more like? And I know I sound like a broken record, but it's like you're reading the vignette. Does this sound like a primary issue or does this sound like a secondary issue? And you can just kind of use that even before looking at the test results, even before looking at a bleeding time or a PTT. It's like, what does this sound more like? Okay. So if the issue is with primary hemostasis, patient presents with gingival bleeding, so the gums are bleeding, continued bleeding after a superficial cut, petechiae and ecchymosis, so random bruising, frequent nosebleeds, menorrhagia. Like I said, menorrhagia is always going to be the key with like females. If they give you a female and it's a bleeding problem, they're always going to talk about painful periods, always. I don't think I've ever seen a question where it's a girl and it's a primary hemostasis disorder, and they don't talk about menorrhagia. But these symptoms here, these will never, ever be the symptoms in a patient with a coagulation issue. And like I said, like continued bleeding after superficial cut. I want to mention like superficial. This is not, I think we talked about last time too, the patient got one of their teeth pulled, it got like a teeth removed, or maybe I think it was wisdom teeth maybe. And it was just like constant bleeding after that surgery. That's not what I'm talking about here. That's like a secondary hemostasis issue. But this is like a superficial cut. Like you just very much cut yourself very like briefly and it doesn't stop bleeding after, 2 to 7 minutes or whatever the bleeding time is for that patient, for that whatever site you're on. So then look at the symptoms and then bleeding time. Bleeding time is always going to be prolonged. No ifs, ands, or buts. With primary hemostasis disorders, bleeding time will always be prolonged. And like I said, you could also see a prolonged PTT. So don't get got with that. And a lot of the times it has to be with if the patient has von Willebrand disease. And not all the time with von Willebrand disease. It's like severe von Willebrand. So it's like, it's kind of hard. Like sometimes you'll be doing von Willebrand disease questions and the PTT's fine. But then you do a question, like the next question, it's von Willebrand disease and the PTT is prolonged. It just depends on the severity. Secondary hemostasis disorder questions, what we did today, patient's going to present with like really intense bleeding. So hemarthroses, they're bleeding into their joints. Late rebleeding. So following surgery, everything's fine. So like let's say the patient gets their appendix out. Following surgery, they're fine, but now they get home, they get put in bed, and it starts gushing again. You're like, whoa, that shouldn't happen. Once you kind of get that intention, that primary intention, like you do the sutures, and it's been more than 2 to 7 minutes, no, not 2 to 7 minutes, but it's like you do that primary intention, and there's no more bleeding, it shouldn't really open up again. That's kind of an indication that there's no clot underneath the sutures there. All right. Other things, like I just mentioned, tooth removal, and it's like bleeding constant after that. Like little things like those are secondary hemostasis disorders. These will never be symptoms in a patient with a platelet issue ever. And here you're going to see either prolonged PT or PTT or both. And then also within this, we're not going to do all the questions. I want to do this one question. I put it first this time instead of looking around for it. But I want to do this together and then can do together for the video. And then all the other questions do on your own, see how they ask these types of questions. Okay, so we have a 9-year-old boy. So boy, will it help? Who knows, but it's good to mention. Brought to the ER, his mom, painful swelling in the right knee. So painful swelling in the right knee that started after he collided with another player. So this, we know this is a hematology question. So this is already making me think like this is maybe bleeding into the joint, right? Like maybe there's painful swelling in the knee. The knee is a joint. He has no history of serious illness except for episode of prolonged bleeding following a tooth extraction a few months ago. So this is what I was mentioning just now. You tooth extraction and you have prolonged bleeding, that's more of a secondary issue as well. Physical exam, marked tenderness, swelling of the right knee joint, multiple bruises on the lower extremities, various stages of healing. This could be primary. So this could be primary. It's hard to tell. But so far, we're like 2 to 1 secondary to primary, right? And this is what I'm saying. When you're doing these questions, like just with the symptoms, it's like, what does this sound more like? Does this sound like a primary? Does this sound like a secondary? Because some of the symptoms can overlap. And then lab studies, platelet count is 235,000. This is normal, so we know it's not a quantitative platelet issue. A PTT of 78 seconds, this is long, so we know this is prolonged. And a PT of 14 seconds, this is normal. Bleeding time of 4 minutes. This is normal. So 2 to 7 minutes, Ambos's reference range. Which of the following steps in coagulation is most likely directly affected by this patient's condition? So you have to diagnose the patient here. So if you're thinking about it, to me, this sounds like a secondary hemostasis disorder, right? I know we have the multiple bruises. This is technically more primary, but overall, you can still have bleeding with a bleeding disorder, right? So like this is not impossible for a secondary hemostasis disorder, but painful swelling of the right knee and then prolonged bleeding following a tooth extraction, this sounds intense to me. This sounds more like a secondary hemostasis disorder. And then the PTT is prolonged, but the PT is normal. Now I'm thinking intrinsic factor. So this is an intrinsic pathway disorder. So common pathway is fine because your prothrombin time is good. So PTT being prolonged, this is either going to be 12, 11, 9, or 8. That's how I got to this point. So now the question, and this is a very board style question, your exam questions would be like, like what factor is likely, like the most likely inhibited or like deficient or whatever. This question is very board style. So now it's like second, third order questions. Which of the following steps is directly affected? So it's asking like what step in the coagulation cascade is probably affected because of the patient's condition. So we know if this is an intrinsic factor pathway issue, and we know there's hemophilia A, B, and C, 12's out because we know it's 8, 9, and 10. So hemophilia A is factor 8, hemophilia 9 is factor B. No, sorry, hemophilia A is factor 8's deficient, hemophilia B is factor 9's deficient, hemophilia C is factor 11's deficient. So 12, we can likely rule that out because it's probably not, it's probably one of the hemophilias. And then just playing odds on it. All of these are X-linked recessive. This is a 9-year-old boy, so we're good there. Playing odds, it's likely hemophilia A. And I know like people get kind of annoyed by this because they're like, well, how do you know? They don't give you they don't give you the option for all three of these, and I'll show you what they mean. But let's just say this is hemophilia A, just playing odds. This is the most common one of the three. So hemophilia A is you don't have factor 8. So if you think about here's factor 8, it gets converted to 8A. So here's 8A. Then what does 8A do? What's the next step that 8A does? It goes to the common pathway and it converts 10 into 10A, right? That's like what 8A does. And so basically what this question is saying, what step in the coagulation cascade is affected because this patient has hemophilia A? So I'm thinking it has something to do with, the conversion of 10 to 10A, and that's right here. So that is what the answer is. Does that make sense? So that's why people are annoyed where they're like, well, it can be hemophilia B, it can be hemophilia C. They don't have conversion of factor 8 as an answer choice. They don't have, conversion of factor 9 as an answer choice. So they don't have answer choices for these guys. But just playing odds, it's probably hemophilia A, but they're like, when people are like, well, is there any way to know from this vignette? No, there's no way to know which type of hemophilia it is from this vignette. You just play odds, and odds are this is correct. Oh my gosh, let me get the chat. Yes, exactly. So in the, for the recording, the way it was worded threw you off. This is how boards are. So you're like, I was looking for factor 8 or factor 9. Exactly. And boards does this, but you'll start seeing when you get UWorld and are doing UWorld questions, UWorld prepares you, they prepare you to answer questions like this. Because this is what boards does, especially STEP. STEP asks almost exclusively second and third order questions. So the answer is hemophilia A. STEP's I know it's way too easy. I know it's hemophilia A. So now they're like, all right, what is, they don't have factor 8. What's going to be affected? What part of the coagulation pathway is affected? So yeah, this is a tricky question, but I wanted to run through it to kind of show you how can you get to a secondary hemostasis versus a primary hemostasis. Here's production of von Willebrand factor. This is your primary hemostasis. If you rule that out right away, you can just kind of rule this out. You don't even have to think about von Willebrand disease at all. All right. And then I just put on here, a lot of people did pick this AMBOSS, 22% is kind of high on AMBOSS. But like I said down here, basically what AMBOSS is saying here is it doesn't sound like von Willebrand disease. this doesn't sound like it. And it says down here, hemarthrosis is not typical of von Willebrand disease. And von Willebrand disease usually manifests with epistaxis, nosebleeds, gingival bleeding, and menorrhagia. This is more intense. And then here's the whole, again, primary versus secondary hemostasis buzzwords. All right, and then all the other answers. But do all the other questions on here. Let me know if you have any questions. And I'm going to stop recording.